Good morning. We're thrilled to be here. I am Fred Brason from Project Lazarus, a group of organization, nonprofit here in North Carolina working on the opioid problem. And we're going to be sharing with you from different perspectives with a community-type collaboration. And we're going to begin this morning with my friend and colleague and Wilkes County neighbor who will share with you her story regarding how her involvement has been and the pitfalls of opioid medication, prescription medications, but how she's able to walk through that and kind of talk about how the system of care did or did not meet, what she needed. So please give a warm welcome.
Hello, I'm Brooke Stanley. I'm a recovering addict. I am honored to be here today. Very nervous, so just bear with me. I have been in recovery for going on 9 years. Thank you. I began experimenting in my teens. I guess a lot of people would probably, consider it typical teenage stuff, smoking marijuana, other things. I didn't feel like I really had a problem. I still excelled in school, didn't get into any trouble. Following a gallbladder surgery in my early 20s, I was prescribed Vicodin. Can you hear me better? Sorry. Following a gallbladder surgery in my early 20s, I was prescribed Vicodin. And I remember very early on realizing that I liked it. Not just that I liked that I wasn't in pain, but I liked the way that it made me feel. Even on that first prescription, I remember taking more than what was prescribed. I went back and got, I know, at least 2 refills, possibly 3. And I was telling someone this morning, talking to people now that have this laparoscopic gallbladder surgery, usually, one prescription is typically enough to manage the pain, but for me, I'm sure I was telling the prescribing doctor that I needed it because I was in pain, and he did prescribe it. After that was gone, I began seeking it out, and that didn't last very long before it wasn't enough, or I was having to take so much that the Tylenol in it was making me sick, and so I started seeking out Percocet. And then not long after that, that wasn't enough. And I remember the first time that someone turned me on to Roxycodone 30. And it was, I fell in love immediately. I had some underlying mental issues that were being treated, obsessive compulsive disorder and anxiety disorder. And so that just seemed to make it all better. I felt like Supergirl. I wasn't afraid of anything. I could do anything. In my mind, it made me better at everything. At that point, I was in college, I was working, I was a mother, and I felt like the medicine made me better at all of those things. For a long time, I was a functioning addict. I maintained, and I hid it from a lot of people that would have been shocked to know the truth. Eventually, though, I started to spiral. I didn't even understand about physical dependency or withdrawals when I first started using opiates. Of course, it didn't take long to realize that when I didn't have it, I became very, very sick. And before I knew what was happening, it wasn't even that I was looking for it to get high anymore. It was that I needed to feel normal. I needed to be able to function. I needed to be able to get out of bed when I didn't have it. Some people will describe it as flu-like symptoms. I laugh when I hear that because it was, the worst thing that I've ever experienced. It is hell to someone in addiction that is dealing with that physical dependency when they don't have anything. Once my family found out, once things did start falling apart for me, of course they sent me to rehabs. And over the course of a few years, I was in and out of many, many rehabs and psych units and detoxes and the rooms of NA and AA, and I would have brief periods of sobriety, and I would do well. Usually right when I came out, I would do well for a little while, but it never stuck, and I never truly got well. Even in those times that I was not using, I wanted to use. It was an obsession. It was all I thought about. I was familiar with medication-assisted treatment. I'd heard about methadone. but I also had heard about the stigma. In fact, I think I'd heard, that was all I had heard, was the stigma, that it was replacing one drug for another, that the methadone clinic was legal drug dealers, that it was a crutch. Even medical professionals along the way that I worked with, would say those things to me. So of course my family, my parents, they believed that and they didn't encourage it, and I felt ashamed to go there for a long time. Finally, when I got tired of living that life, when I was on the cusp of losing everything, I decided, why not? What do I have to lose? There was not a clinic in the area I live in. It was, the closest one was about an hour away. And so I decided to make that drive one morning. And for those first 90 days, which is what it took me to get to a level where I didn't have to go every day, I drove every morning that hour, and every morning to get out of bed, I had to tell myself that it was going to be worth it one day, and it was. I had immediate success on methadone. I was at that clinic for about 4 years. I think I failed one drug screen in the first month of treatment, and I've not failed a drug screen since. I came out of that clinic. I spent about a year detoxing, just as the doctor there recommended, because I'd had such success, it seemed like the logical thing to do. After that year of detoxing, very slowly, I was very excited to come out of treatment and say that, that I was not on anything, that I was going to do this on my own. About 2 to 3 months following that, I was diagnosed with post-acute withdrawal syndrome, which something else I had no idea what it was, had never heard of it. What I did know was that when I came out of treatment, I came off the methadone, that I was not normal, I was not right, I was not healthy, I was not well, I couldn't sleep, I was anxious. My family doctor, over the course of those few months, had me on Xanax and Ambien and Paxil and multiple other things, trying to treat those symptoms and help me to get some relief, and nothing worked. I never felt well again. So I had to make the tough decision to start back. At that point, there was a clinic in the area I live in, and that was about 4 years ago. It was at that point that I had to make peace with the possibility that I would be on methadone or medication-assisted treatment the rest of my life. But I have made peace with that, and it has allowed me to go back to school. It has allowed me to have a fabulous job where I get to help clients that were in the same situation that I was in. I'm able to serve on committees and boards, and I'm able to be a productive member of society, and a good mother and a good wife and daughter. So I'm interested in speaking out and breaking the stigma and helping others to understand how beneficial medication-assisted treatment can be and how it's needed. Thank y'all.
Thank you, Brooke. And through our sharing with the individuals here, that each one will introduce themselves and the part that they play in the community collaboration, we'll have ongoing discussion with Brooke about the mishaps, the starts and stops, and the failures and the successes, so we can all learn from that. And anytime a gathering like this, we all want to, we come in with something, but we also want to go out with something more. And just to give you a little bit of history of how I got involved in the prescription medication, opioid, benzodiazepine issues in Wilkes County, North Carolina, I was a hospice director. I had no clue about what was going on with medications being shared, stolen. I had no clue that our county was the third worst county in 2007 in the United States for overdoses from prescription medication. Until I started to ask questions and to delve into that. So I was involved in end-of-life care, which means there's potent medications, but we had families stealing it, we had families sharing it, we actually had families selling it. And so that's how I sort of got involved, but as I did that, I began to realize, and I want you to ask yourself these questions, in your own life, both as a person and both as a professional. Why are you needed? What do you need to know, and what needs to be done? And that was kind of the crux of what we did with community collaboration, and that's what you're going to be hearing about today, because that, we have learned, is the critical mass that is necessary to address this issue, because it's every community throughout the entire United States that's dealing with it. And we know from history how we got here. And it didn't happen overnight. This has been a trend that's been going on, since the mid-90s, and we've known that substance use has been around forever. But as this developed, there's many different reasons, and part of those reasons are it was made in about 1999. There was a determination that for wellness, for you to get care, for you to get treatment, that you had to be assessed, and and the prescriber practitioner had to document, the treatment of your pain, wherever and however that was to be. And they had made it the fifth new vital sign, which means the practitioner had to ask you that question. Do you have any pain? Yes, I do. Okay, where is it? All right, next question, on a scale of 1 to 10, what is it? Well, that's totally subjective. And then you couple that with hospital systems, emergency departments that were into patient satisfaction and the patient bill of rights saying you have a right to be pain-free. Well, to have good patient satisfaction scores, you basically have to make sure people are quote-unquote pain-free, when most practitioners, the only thing they had in their arsenal and their toolkit was to write a prescription. So those are kind of all the different trends that sort of built into this. That doesn't make doctors the bad guys. That doesn't make hospitals the bad guys or the emergency departments. It just means we had to do better practice. So we brought to them, and working with prescribers on, why are you needed, and what do you need to know, and what needs to be done, so that we could build best practice. And that's what we did in Wilkes County, and now that's kind of filtered through all of North Carolina. Now the American Medical Association and many others have come out with guidelines. The CDC has come out with guidelines to make sure that everybody is doing best practice. But on the other side of it, we got here too because for anybody that lives in a rural community, actually most any community, but at least in rural North Carolina, and I'm glad to see Geisinger here. I grew up in central Pennsylvania and still travel up there on this issue quite a bit. We've learned that 70% of the diversion is between family and friends bought, stolen, or shared with prescription medications. That's not something that's happening in a back alley. That's not something that's happening in the secret. It's happening in the schools, in the workplace, in the home, in the living room, in the bathroom, family, friends, aunts, uncles, and parents and siblings sharing. So that's some of the practice that goes on because, we always want to help people and if we have some extra meds and somebody needs that med for an ailment they might be having, people unfortunately freely share. But in doing that, we realized that it was affecting everybody. We had patients misuse accidentally, not knowing that if they took more pain meds than what was prescribed, they could possibly overdose and die. We had children getting into medicine cabinets. We've had, family and friends die because they shared medication. And then we have individuals, like Brooke just talked about, who, once you start taking it and you take more and you take more and you take more till you get to that point where, you're literally every single day on that edge of a respiratory depression and an overdose from the opioids that you may be taking. So we realized we had to reach everybody in the community. There's nobody that's left out of this, every age group, every population group, and that's why when we talk about collaboration, it has to be person-focused, and from there we can talk about population health and public health. But every community is different, so we have to make sure that we reach into, every individual, and that's what we did. We designed it to where we would work with the prescribers and their education, that we would work with emergency departments to give them the tools that they needed to, appropriately prescribe, which means, we're not giving out 30 days, we're not refilling controlled substances. We're going to provide you with pain relief, but we're going to make sure that we give you a referral to either a pain specialist, a primary care, or behavioral health, or addiction treatment, whatever that may be. And that took community collaboration to make sure all of those pipelines were interconnected, as you can see, that we're talking about on the infograph on the screen. Everybody is networked together, and that's where we have found success in doing that, yet in no case are we denying anybody care. We're just ensuring it's best care and making sure that everybody who is, what do I need to know and what needs to be done is connected, and the messaging or the practice is done, across the board. And that's where we've had success in North Carolina and other places. In Wilkes County alone, our first couple of years, we reduced overdoses by 69%. Over a 5-year period, over 50%. And again, in 2007, we were the third highest in the nation with that statistic that, we don't like and don't want. But at the same time, we're going to talk about, law enforcement, we're going to talk about harm reduction, we're going to talk about addiction treatment and behavioral health. And we've worked on some behavioral health initiatives, and I, heard with all your awards this morning, integration of behavioral health into primary care, into the system of care within our communities is essential for us to move out of this, but then to provide best care ongoing. Together with our Mountain Area Health Education Center over in the Western North Carolina, we worked on a joint project with the community and integrating behavioral health. And guess what? It worked. People got care. Opioid use went down, yet we still provide care. People still need the prescription if they have it, but then more people are getting into medication-assisted treatment because it's readily available. More people are being referred into the system of care, but then the community comes together to support the individuals that need it, whether it is pain patient support, whether it is addiction support, surrounding that, and that's something that we'll ask Brooke about. How did the community meet you in that support mechanism, or did they just say, go here and get your treatment, or go here and get detox, because that's where we found, the gaps to be. So as we share this with you, we have had successes, but look at it overall from what you can personally do, but then look over it collaboratively as to how you can integrate your entire community in what you do every single day, and make sure that somebody else knows what you do, because they might know somebody who needs to be referred to you. Or you might find somebody that you know that needs to be referred somewhere else, whether it's the support, whether it's the need, or whether it's the medical care or the behavioral health care that needs to go on. So from my perspective, it is that collaboration. And now Don Teater and Katie Getz are going to share on the addiction perspective and the medical care. Thank you.
So Katie's told me I got to do all the talking. She is my support person, though. We both work at Meridian Behavioral Health Care in Waynesville, North Carolina, and I've been there for a number of years, and Katie and I have worked together on a number of patients, and I provide the medical care, and we've got a great support team and a lot of excellent behavioral health specialists that work with us, and it's really been a great experience. A little bit of my history. I am a family doctor. I'm board certified in family practice and actually have worked in an integrated care setting since 1990. That was actually when our youngest son was born, and my wife, who's a behavioral health care specialist, came and joined me in practice. We had a small practice most of those years. We like to say that our practice was integrated to the highest level. But really, we shared a lot of patients, and even in the evenings, we would talk about, their care and their situation, and it brought a whole new perspective for me and how to treat folks. So I certainly support everything you guys are doing. I think integrated care is the ideal in how we provide medicine. I think one of our problems in medical care is that we separate mental health from physical health, and that you just can't do that. So, I certainly support all these efforts, and it's made a huge difference in my life. In my wife and my practice for many years, we did some addiction treatment, because that's actually how she started her career, was in addiction treatment. And in the early 2000s, we began to see a lot of people coming in addicted to opioids. So in 2004, I got certified to prescribe buprenorphine or Suboxone, and treating those folks that suffered from opioid use disorder, and it changed my life. So I saw people like Brooke coming in, some of whom I had gotten addicted on the medications because I prescribed too many. And I saw how it had just gradually taken their life in a direction they had never intended on it going, to the point oftentimes where they'd lost their family, they'd lost their jobs, they had no money, they'd been arrested several times, and they just didn't know where to go. They were able to come to us in my family practice. I was able to start them on the buprenorphine. My wife did counseling, and we saw lives change dramatically, just like you heard Brooke say her life changed. And it was so incredibly rewarding to see that. I would go out in the waiting room and bring my patients back when they came back for follow-ups, and I'd hear them talking in the waiting room about how their life had changed and about how I had saved their life. And it wasn't me, I'm doing my job. But it was just very rewarding. And I love primary care, I love family practice, but much of it is treating people with diabetes and high blood pressure, and sometimes it feels like I'm making more effort than they are, and people just want a pill anymore. That's part of the reason we got into this problem. So anyway, it changed my life, meeting folks like Brooke and hearing their story and being able to help them. I encourage all of you that are in primary care to look at doing addiction treatment, to look at doing buprenorphine treatment in your practice. It saves many, many lives. It's a wonderful thing. But I did want to share a little bit how we got to this point. So the CDC has really showed us that our opioid problem, our increase in addiction admissions for addiction treatment, and our increase in overdose deaths is directly related to the number of opioids we prescribe. So we clearly prescribe way too many medications. Brooke's case is a great example. You said you had gallbladder surgery. How many did they give you with that first prescription?
I believe it was 30.
30. And then you called for a refill and they gave you more.
Yes.
Right. So it's very common these days for people. I worked at the National Safety Council for a while, and we did a poll of doctors, of primary care doctors, and 1/3 of them, for acute pain problems like this, gave people a 30-day prescription or more of an opioid. And we know by that time the opioids cause some brain changes that cause some physical problems that Brooke experienced, actually. So, we've gotten so we prescribe so many of these. The United States now, we consist of 4.6% of the world's population, and yet we consume 80% of the world's opioids. So, this is a uniquely American problem. I have kind of lived through this increase in prescribing. When I first started prescribing, if you had gallbladder surgery, you would get some opioids in the hospital, but when you went home on ibuprofen, right? We almost never prescribed them as an outpatient. We were afraid of addiction problems, to be frank. But then we were told that that's not correct. People don't get addicted, so we started prescribing more, all in a legitimate effort to try to relieve pain in America. We thought this was the answer. So over the course of about 10 years, from 1997 to 2007, our opioid prescribing went from where we were prescribing an average of 96 milligrams of morphine equivalent per person per year to where we prescribe more than 700 milligrams per person per year. So it's even gone up a little bit more than that now. We're about 725 milligrams per person per year. That's enough for every man, woman, and child in the United States to have 140 Vicodin tablets every year. And yet a number of studies have shown that the pain levels in the United States during that time have gone up. We actually have more pain in America. And the reason for that is because now we're deciding that opioids actually lead to more pain. So what they do, the opioids work in kind of a special way in our brain. And what they do is they not only stimulate dopamine, which makes you feel good, but they also activate these opioid receptors. And we have opioid receptors for a purpose, and it's not to relieve pain. Opioids help us achieve a goal. They help us reach our goal that we're going for. So they give us motivation. They give us confidence. I think, Brooke, you mentioned that. What were some of your feelings when you first started on these?
I felt invincible. I felt like I could do anything. Any anxieties that I had prior to using were gone. It gave me energy.
So that's exactly what I hear from my patients that I admit to addictions treatment. They say this. So one of the examples I often use to kind of explain what the opioid receptor does is remind people of the Wizard of Oz story, where Dorothy has been in the woods and all these bad things have been happening to her, and it's just been a very difficult time. And suddenly she comes out of the woods and here's this field of poppies that the Wicked Witch had placed there, right? And immediately her anxiety, her fear goes away. She has energy, she has confidence. She and her friends are linking arms and they start skipping down the yellow brick road, right? And that's how you feel, right? Down the yellow brick road, yeah. So these are all the opioid receptors being activated. That's what they do. So the problem is, though, that our body knows that we're supposed to feel pain and we're not supposed to have that much activation. So with our first dose of the opioid pill, our body starts to react by decreasing our opioid receptors in our brain. And the more we take, the more they decrease. And one of the real key things that opioid receptors do is they do relieve anxiety and depression, right? You mentioned that. So actually some studies have, and even before we had antidepressant medications, before we had Elavil, we used morphine to treat depression, but many people got addicted to it, unfortunately. But now they're using buprenorphine to treat treatment-resistant depression because it resolves depression within 15 minutes. It's almost miraculous, right? But that effect wears off. And so the more you take, the less effect it has, and you have to take more and more. And so you find after you've been on it, after your doctor has kept you on it for 2 or 3 weeks, after you come off, you have this really bad rebound depression, increased anxiety, increased pain. You're feeling pain more because you have less opioid receptors, and there's actually other changes that occur to the brain neurons to make it so that you'll feel pain more. So many people start on these, and as they try to come off, their pain gets worse, their anxiety gets worse, their depression gets worse. They call their doctor and they get another prescription. So, what's the alternative? So clearly opioids are very dangerous. They're obviously the most dangerous pain medication we use. But what's the alternative then? Well, interestingly, a number of studies have looked at this and have looked at the effectiveness of different pain medications. So again, for those of you in primary care, I encourage you to look this information up. And I've got it on our website. If you contact me, I'd be glad to get you some of this information. But it actually shows that taking one over-the-counter ibuprofen relieves pain as well as taking 2 Percocet pills do. And if you actually combine the ibuprofen with acetaminophen or Tylenol, it's 60% better than 2 Percocet are at relieving pain. So people after gallbladder surgery should be going home on these treatments instead of the opioids we're giving them. People with dental pain, this is where the studies were first done with people that had their wisdom teeth removed. These people should be going home with ibuprofen and acetaminophen, over-the-counter doses. But we're so quick to write these prescriptions, and we're getting folks in trouble with this. So as we do this, again, I will kind of relate my experience in primary care. You know, as we see these folks, as we get them on the medications and they develop this problem where they're having a hard time getting them off, we need to be able to recognize addiction. We need to be able to treat it. So again, I strongly encourage any of you to look into doing buprenorphine treatment in your office. If you have a methadone clinic in your community, you know, talk with them, work with them. Medication-assisted treatment for opioid use disorder is extremely important. And it's important because opioid addiction is different from other addictions. All addictions stimulate dopamine, right? Cocaine, methamphetamine, marijuana, all that stuff stimulates dopamine secretion. As people get off of those and they get in an abstinence-based program, gradually that comes back. People addicted to the opioids, though, they also have decreased their opioid receptors. And as I mentioned, the opioid receptors are important to help us achieve a goal. So they give you this feeling of confidence. They give you this energy. They take away your anxiety and depression. So as you come off of them, you have this feeling where, you know, first of all, you hurt all over for a while, but even after you go through the withdrawal, your opioid receptors are not there, so you don't have this confidence. You don't have excitement about life. You're anxious. You're depressed. And it's just a very difficult feeling. As Brooke said, you know, they called it post-acute withdrawal syndrome for her, but it's this opioid receptor that doesn't rebound. These people just have to have medication. So tell us what you felt like when you started on your medication. I think medication assistance is very much misunderstood. Tell me how you felt with that.
I started to feel normal again. I got my life back. I was able to sleep well again. I was able to get up and be productive. I had energy. I felt good. It was what I consider to be my normal.
Your normal, right.
Before I ever started using opiates.
Right. So because your opioid receptors are so depressed, you need a medication that can help stimulate those that are there to a level where you feel normal again. So there's a misunderstanding that people go to methadone clinics and they get their methadone to feel high again, or to kind of substitute one addiction for another. But it's not. It's replacing those chemicals that are needed in the brain. And studies have shown that people that get on medication-assisted treatment, some are able to come off, but many are not. It may be as many as 60% of people, their brain receptors never get back to normal, and they have to be on medication assistance the rest of their life to feel normal. That's all it does. You don't feel high. You take the dose once a day. It's like taking a vitamin. And it makes you feel normal. That's all. So, you know, I strongly encourage expansion of medication-assisted treatment. The studies have looked at people that go through the detox and abstinence programs like she tried, and it's got a very, very high failure rate. As many as 90% of people will be using again within 6 months. So it's very difficult. Naltrexone, injectable naltrexone is Vivitrol, and it works differently from the other medications. It's an opioid receptor blocker. It gets on there and makes it so that if you take anything, you don't feel it. But the problem is it's blocking those few opioid receptors that you have, so these people tend to be depressed. They don't get anxious. They don't have fun with their families. They don't enjoy doing things. And so it has a very high dropout rate also. So it's, you know, abstinence-based treatment is okay for some people, but it's a minority. You need to carefully screen these folks because the incidence of overdose is very high when they start using again. Same thing with the naltrexone or Vivitrol. You know, it works for some people, but really the buprenorphine and the methadone are the treatments of choice. So I also want to mention some of the mental health aspects of this. So she mentioned the anxiety and depression that she felt as she tried to come off of it. So many people that I see that get into the addiction with the opioids, it's because it was treating their anxiety or depression. Many of them will say, I've been depressed all my life. You know, I was on all the medications, Prozac, Paxil, Effexor, nothing seemed to work. And I sprained my ankle, my doctor gave me that Percocet, and the first dose, it went away completely. It's miraculous. And so they start taking it for that reason. But that effect wears off even faster than the pain-relieving effects. So we see people, they're kind of at their baseline, they take the opioid medication and their mood goes up. They feel better. But then as the pill wears off, it starts to go down and it goes a little bit below normal until they take their next pill, then it goes up. But each time it goes up, not quite as high. And that gradually that comes down, that up and down keeps getting lower and lower until finally you get to the point where the dose you're taking doesn't even get you back to what used to be normal for you, right? Yeah, and so, you know, here you are, you're feeling horrible all the time and pretty bad the rest of the time. And so you have to take more medicine. You have to get the 30 milligram oxycodone to help get that effect back to where you're feeling normal again. So people with mental illness, with mental health issues, whether it's anxiety, depression, bipolar, in particular, some of the mood disorders, the opioids fix those immediately. So these people getting acute prescriptions are at huge risk of developing addiction. So, I think people getting acute prescriptions for opioids, even if they're short-term, there should be some screening to look for mental health issues. And clearly we need to be addressing that as we get them into treatment, whatever that situation may be. Anything else you want to add?
It's just really exciting to see the interest now that doctors and everyone that's involved, mental health care professionals, have in learning more about medication-assisted treatment, and that to see the shift with the stigma that it's changing.
It is changing, and I agree, but there still is a huge stigma, and we all need to make some efforts at reversing that, because again, I see that in my patients. They will go to the emergency room, and the doctors there will tell them, you got to get off this medication. You're substituting one addiction for another. How many times have you heard that?
It still happens to me all the time, even where I'm at now with the success I've had.
Right.
I've had someone tell me, not even in the last 3 months,
Right.
that I needed to come off of it.
So addiction is a disease just like diabetes is, and when I talk to doctors, I try to explain that there's partially a genetic component to it, but it is caused by physical changes. These are physical changes to the brain, whereas diabetes is the liver and pancreas. We oftentimes need medication. Some people can get by doing behavioral changes, but for both diseases, it's about 10%. About 90% of people need medication. There's no cure for either one, right? We just try to get them under control. There are relapses with both of them. My folks with diabetics, if they come in and their blood sugar's really high, I don't fire them for that, right? We double down and address what the issue is and work on that. So they're very, very similar. We need to understand disease as an addiction. I sat next to a man in a meeting just recently who his 21-year-old son had recently died. His son had been on buprenorphine or Suboxone treatment successfully for a couple of years. Went to a new doctor. The doctor said, you're substituting one addiction for another. You got to get off of it. Weaned him off of it. After he came off of it, he was abstinent for about a month, and then he took a dose of heroin and he overdosed and died. So, we need to begin treating this as a disease. We need to understand it's a disease. We need to understand that we in the medical field are contributing to it. We were trying to treat pain appropriately. We know now there's better ways to do that. We don't need to be prescribing all these opioids, and we need to keep people from getting into this situation in the first place. So, thank you.
Thank you, Don. I first met Don probably back in 2008 in Waynesville, and I believe, and correct me if I'm wrong, you were the only provider in pretty much that region for buprenorphine addiction treatment. How did you find the community response to what you were doing? So
let me say, in the addiction community, and the community of the people I was serving, word spread like wildfire. So I had some of my patients would drag people into my office that they said, this person needs your help. So very positive in the addiction community, but otherwise the reception was pretty much lukewarm. And the ER doctors and the surgeons, none of them understood it at all. So I was trying to talk to them, explain why this person was on this medication. But it's more, it was just kind of confusion, I think, more than anything else. They didn't really know what to make of it. And most doctors, they still don't understand addiction. We get no training in addiction. Right. Mm-hmm. We get very little education how to treat pain. So it's all very foreign to them. Right, okay. And Brooke, as I was just talking to you, you first went on methadone how many years ago?
It's been a little over 8 years ago.
8 years ago, in our community in Wilkes County, Brooke had to drive 45 minutes to an hour each day in order to get that treatment. And you all know that anybody has to do that much every single day. It pretty much is setting up a failure for treatment.
There were so many people that wanted treatment at that time that I was using with, that I was friends with, that didn't have transportation, or had lost their license, and didn't have the ability to get the help that they wanted.
And as I started to look for treatment to come into our Wilkes County, the first meeting that we had as a public hearing, public meeting to discuss methadone, I thought they were going to send me back to Pennsylvania, literally. It was not something they wanted in their neighborhood, not something in their county. They didn't want anything to do with it. It was for a drug. So we did begin with buprenorphine, and now your methadone clinic is very close to where you live, and they are treating over 500 people in our rural community right now.
And Fred, let me just say that there is a slight difference between the buprenorphine and the methadone.
Yes.
Methadone is stronger and more effective. So not everybody is successful on buprenorphine, but many people are, and it's hard to know ahead of time based on how much drug they're using, whether it's heroin or whatever. So many times, I think now that buprenorphine is more available, generally that's the first trial, the first drug that should be tried before you get into a methadone clinic. Methadone is much more dangerous. It has a lot of drug interactions, and it's a much more dangerous medication. And in particular, when you're starting them on it and increasing their dose, there's a lot of risk to that. So buprenorphine is usually the drug of choice, but in some cases it's not.
Yeah. Every individual is different, so treatment needs to be different. Yeah, thank you. And just to show you where we've come, Brooke, you started on opioids. You got a 30-day supply when you had your gallbladder surgery.
Yes.
I had that same surgery this year at the same hospital a good number of years later. I got 9 tablets when I walked out of the hospital. So there have been changes, and I had to throw 8.5 out because I didn't need them. So it just shows you, that things can be done. Now we can move on to Donnie Varnell, and he will be sharing from a law enforcement perspective and how that is.
Again, I'm Donnie Varnell. I am recently retired from the State Bureau of Investigation. As I always tell people, prior to that, I was a deputy sheriff and a Wilson City police officer. As I tell the locals, I was the real police before I got the state job. And Uncle Sam gave me the opportunity to jump out of some airplanes during my formative years. So I'm a little bit more familiar with pain medication than a lot of people in this room. I will apologize up front for speed talking because we're really short on time. But I want to start with thanking Brooke for sharing her story. If I could have every police officer in the country hear you speak, you could not believe the world of good it would do. I will tell you that in the last 30 years, police officers have all kind of had the same thing. They've had some tools, they've had training, and they've had direction. Your law enforcement agencies have done fantastic jobs with that. What they were told to do, just like everyone in this room, what you've been trained to do, they did very well. But they were not trained to treat people as individuals when it came to substance use, especially now that the opioid epidemic has hit. But what the result was many, many thousands of people were incarcerated for low-level drug offenses. And I contributed to many of those arrests. That was what I thought my job was. But what we found over those 30 years was this. We didn't stop substance use. We certainly didn't stop addiction. And me arresting you or the threat of being incarcerated did not stop you from using opioids. I think Brooks would say that's true in your experience. I have no idea what Brooks' past is, and I'm not asking, but I know that Brooks' story very often has a point where they have a negative contact with law enforcement because the use turns into what is in black and white a criminal offense in North Carolina and most of the nation. But those incarcerations didn't stop it. And what we ended up with was that on any given day, you have 1 out of 100 Americans are behind bars. 70% of everybody, and law enforcement has ever said 70% of all our crime is substance abuse based. Your thefts, trespassing, domestic violence, low-level drug offenses, trafficking, it all goes back to substance use. And if incarceration doesn't work, we decided we had to do something else. We were not well trained to handle the opioid issue when it hit. We didn't know to treat individuals a certain way. We used stigmatizing verbiage in their presence very often. Their family members used the same verbiage in their presence very often. And so we weren't helping. And I will tell you, as police officers, all we want to do is help. We never care who you are. We don't care how much money you make. We don't care what kind of car you drive. We don't care what school you went to. Well, there's that one blue school. I mean, I don't know about that one. But see, a lot of you don't know what color blue I was talking about. All right. But when the phone rings and the bell goes off, we come running. That's just what we do. We want to help people. But we didn't know how to help that community. So what we have done, when I took over the prescription drug unit in the SBI, we call it the diversion unit, I realized we had to make some changes. Our overdose death rate, which is a tangible number in law enforcement, was going up every year. And we were trying to deal with that, and I knew that traditional methods were not working, so we took some steps. One is we started a training program with a grant, and we trained about between 1,500 and 2,000 police officers, one, how to investigate that type of prescription drug and now heroin investigations, how to do that correctly, but also how to treat people as individuals, how not to be adversarial with a person that was obviously struggling with their own substance use, and that any criminal violation that they were involved in was really just to, as Brooke said, to stay normal. And we always now tell officers, people aren't trying to party and get high, they're trying not to be sick. And you wouldn't let your own child be sick. You would do anything to keep them from being in that kind of pain. So why would you expect someone not to do it for themselves? And we also taught officers not to be adversarial with the healthcare community. My unit specifically investigated healthcare providers for substance abuse issues and for illegitimate prescriptions. We had to find a better way to work within a community. So I was fortunate that people like Fred and the doctor and Robert Childs, you'll hear I'll talk to later, would invite me to these committees to get the law enforcement side, and I would come running every time. I would be the token police officer in all these groups. And it was a great opportunity for me to know that 99.9% of everybody that gives health care is doing absolutely the best they can with the training they have. So we started training the healthcare professionals what to look for so that you know that maybe you're being scammed. Someone's using your identification to write false prescriptions. So we pushed the controlled substance reporting system that people would use that to give better health care and maybe catch issues that maybe Brooke was looking at in the future, before it happened. But now that I've gone past that, we try to find different avenues for law enforcement to deal with individuals when they meet them on the street. And that's what's kind of exciting now. There is a shift in the criminal justice system that we're trying to get away from arresting individuals for what we know the American Medical Association calls a disease, is addiction. Instead of trying to arrest that out of people, we're trying to get them into the systems that they need. A couple of little things, and Robert Childs will talk about some other programs that we have in the North Carolina Harm Reduction Coalition, who I now work for, by the way. And one is this: we have the declaration law. So if I approach an individual on the street now, I now have new training as law enforcement. I know that if this is going to be a low-level drug issue, there's other options. I never was told as a police officer what treatment really was. We always heard, go get treatment. You need to make a phone call, get some treatment. Get into rehab, whatever that meant. We had no idea. But now we kind of know through our training, when we train officers, how to get people into the system. Who is a real person to contact. But if a person now tells me that they have a syringe, then I don't charge them for that syringe. Now that might not mean much to you in this room, but that is an arrest that a person who is struggling with their addiction doesn't have to go through. They don't have to go into a jail cell for 72 hours until they get out, and now they're so much more likely to overdose when they come back out, because we know in law enforcement at least 80% of all the heroin use comes directly from stories just like you heard from Brooke, that they have started on prescription medication. They can no longer get enough prescription medication to cover their needs, and it's too expensive, so they go to heroin. That's why we have this. I know that last year was a 500% increase in heroin overdoses, and I know this year it's going to go up to about 800%. So the heroin is directly connected to prescriptions that are written. So we know that that's a chance for that person not to be incarcerated and maybe to get that person in treatment. We now have a program called LEAD, which is the Law Enforcement Assisted Diversion Program. Fayetteville, North Carolina is one of 4 programs in the country that are running. And there's 5 other pilot programs that are trying to get up and running but haven't yet. And what's exciting about that is that's a pre-booking program. So as a police officer now, I told you about those tools, training, and direction. I had almost no options as a police officer. If I came in contact with someone with Brooke's story and they had a syringe or they had illegal substances on them, I couldn't even have discretion anymore. There was a time, you might find this odd, police officers would take marijuana cigarettes and throw them in the dirt after wadding them up and take people back to their parents. But that discretion got squeezed out of law enforcement. We can no longer do that, because if we threw one marijuana cigarette away and didn't throw the other marijuana cigarette away, we were showing bias. So the way police officers did that is, well, then we'll incarcerate everybody. We've got past that now, thank the Lord. So now, instead of taking that person to jail, I can take a person in the LEAD program straight to a case manager, and in Fayetteville, that's what we're doing, straight to a case manager, and then I leave as a police officer. I go back on the street so that when your house is being broke into at 3 o'clock in the morning and you call for real help, a police officer can come. I'm not at the magistrate's office processing someone that's going to get out in 24 hours and go back, right back into the cycle of use. So that person gets wraparound treatment, and in our world, we know wraparound treatment is housing, job placement, food, emergency housing, and yes, rehab. So that is a program we're going to see that's going to take off in North Carolina. There's already 4 other agencies that are in the process of making a LEAD program. And we hope that these options like this, options that keep people out of incarceration and use police as a conduit to go into the correct treatment and service programs, is something that can break the cycle of arrest and get people the services they provide, that they need be provided to them. And that's all I have right now. Thank you very much.
Thanks, Donnie. Just a couple questions. So we can put this into an application mode, because I know what we've been doing among the coalitions and getting law enforcement, emergency department, crisis intervention, behavioral health, primary care, all kind of involved, and we meet monthly in order to help out with what's going on in the community. With the LEAD program and a case management, how does that integrate into the community to find those wraparound services, to find that behavioral health care or mental health care? How is that working?
Well, the program in Fayetteville is in its beginning stage.
Right.
We actually started the program as a soft launch about 3 months ahead of time, to the chagrin of places like Los Angeles and Atlanta and Baltimore that are still trying to make it happen. So the metropolis of Fayetteville jumped ahead in that. Fayetteville, go Fayetteville. But what we have found is already, and we only have 3 people that have gone into the program, but already the community is starting to call the police now and saying, how do you get into that LEAD program? Which we did not expect to happen that quickly, but in the other locations that have the LEAD program, Seattle, who's been up and running for about 3 or 4 years, and Santa Fe, they're seeing the same thing. Once it's accepted, once the population realizes that the police are really telling you the truth, because there's a trust issue in this, right? Like, Brooke could probably add, she has friends or associates that probably don't like to see the police roll up, because as I tell people, we never come to the birthday party. When the police come to your house, something is probably your worst moment. That's why we hate firemen so much, because everybody loves a fireman. But the LEAD program has become almost a public relations thing, where people now starting to see that there are treatment options. And just a few people that go through the program go back into their community and tell their friends and associates, hey, there's an option, even if you don't have any money, because we found that a lot of people that suffer through this issue have no idea how to get help. Or they're told to get treatment and they don't have any money, and it's like they make one phone call if you're lucky and they go, well, there's no bed. How many times have we been told that? There's no beds. Or a parent is told there's no bed. Or the cop that really tries to help is told, well, we can see him in 6 weeks. Well, that's 1,000 lifetimes to someone that's suffering. So we have found that already the community is starting to see there's programs that they can get into. So we think that's a conduit that's going to build for every person that goes in. Many people will know about the program.
Excellent, because it is vitally important that everybody is working together like that, because we've seen the results in that, and rather than just locking people up. There's actually police departments in the United States now that somebody can walk in the door with their paraphernalia, with their drugs, and say, I want help. And they will confiscate that paraphernalia and drugs and then turn that person over to a case manager in order for them to get help and not arrested.
And I'll add, the LEAD program is the LEAD program being post or pre-arrest is unique, that once I come in contact with you, like you don't even have to come into the office. The Hope and Angel program that you're speaking of is fantastic programs. But we were fortunate in Fayetteville and in the other locations that the LMEs and MCOs are stepping up because we have zero funding, right? I mean, is everybody familiar with zero funding? But they have stepped up, like in Fayetteville, it's the Alliance Behavioral Healthcare, Trillium, Partners, people like that are stepping up to use that indigent funding that they have to put people into these services. So, I mean, someone's still paying for the services, and probation and parole has stepped up. I mean, if anyone is familiar with these agencies I'm talking about, this is not a group that usually hangs out. Probation and parole, health care, law enforcement, the district attorney's office, the town council, the town commissioners, community watch, the faith-based communities have all come together. And it's almost like the epidemic, in a way, has reached its crest where it now affects everyone. Where at one time there was a group of people that thought that was another person's problem, and now it affects so many people. We just kind of find this unbelievable buy-in on these kind of programs where people want the help. So, and besides someone coming into a police department, in the LEAD program, I actually make a contact on the street where normally you were getting arrested. That is what the result was going to be. But with the LEAD program, now I have that option given to me, another tool, as you say, in my toolbox as a police officer, that if I think you fit the program or you meet the parameters, then I don't have to arrest you, and it's okay. I take your evidence and put it in my pocket, put it in evidence later to be destroyed, and I take you to treatment. And we just think it's going to be, I mean, we are sure that it is going to be a statewide program in a couple of years. It's going to be the new buzz.
Probably quicker than a couple of years.
I hope so.
Yeah. One thing Donnie mentioned, I just want to highlight it. He talked about a prescription drug monitoring program, and we have that here in North Carolina, and 49 states in the United States have it, and that's where you can go in and look at the person's prescribing history for controlled substances. And Pennsylvania just initiated theirs. One of the things that we found in a program such as that, as a primary care practitioner is looking at that patient's history, and they find that, oh yeah, they are seeing 3 other doctors, or they're doing a urine screen and finding, well, with the prescription I'm giving you, I'm not finding in your system, and the immediate response is, well, I'm just not going to prescribe to you anymore. I'm just cutting you off and I'm firing you from my practice. And that is sending people out into the street, which then leads to heroin, unfortunately. So it's vitally important that when we've got prescription drug monitoring programs, that there's a tie-in with the primary care, with the surgeon, the orthopedic person, and making sure that when they do find somebody, they aren't just sending them out, they're keeping them in, and that's where the integration of behavioral health comes in, because it's right there in the practice. And instead of sending somebody out the door, you're sending them down the hall to the social worker, the behavior care specialist, whatever is necessary, or the addiction treatment. So and I'm just emphasizing again the networking that needs to go on. But now we're going to hear from a good friend Robert Childs on what's happening at the street level.
Hello. My name is Robert Childs. I'm the Executive Director of North Carolina Harm Reduction Coalition. We're the only comprehensive harm reduction provider in the state of North Carolina and our surrounding red states. So before I go off talking about harm reduction, do you guys even know what harm reduction is? Okay, right on. So how many of you here drive automobiles? Everybody besides table number 9. Okay, so driving a car is the most horrible thing for your health. What happens in cars besides whoopee? You guys know what whoopee? Some of the younger generations may not. It's making love. So besides making love in automobiles and occasionally getting to work placements and conferences, you pretty much may just get in an accident or die. That's pretty much what happens in cars, right? So we, as we grew as a society and got more interested in this weird public health thing and public safety, we decided to do some things. Name a car-free society in first world nations. There are none, right? Thus, if we know everybody's going to engage in horrible health behaviors, why don't we try and make it as safe as possible? Let's drive Volvos. Let's use cars with seatbelts and airbags. That's harm reduction. We take an inherent bad behavior or dangerous behavior, driving, and make it as safe as possible. Our agency does the exact same thing with drug use and sex work, right? We know, name a drug-free society. Name a drug-free society ever. It doesn't exist, right? We will never have a drug-free society. That just will never happen, right? Can anybody name a drug-free society for me? Zero. So if we know there is 0 drug-free societies, let's help people who use drugs, let's help people who do sex work and survival sex be as safe as possible while they're in the boogie, right? And then let's give them tools so they can get off of that when they're ready for it, right? So let's give them methadone, let's give them buprenorphine, let's give them social support, let's help them with housing, let's help them with decriminalizing health behaviors such as the failed war on drugs, right? Drug war is a massive failure. 1918 Harrison Act is why we have criminalized opioids, right? So has it worked over the last 100 years? No. So our agency works to reform that. So we've done everything from decriminalizing calling 911 in North Carolina. So we had mothers being criminalized for calling 911 when their kid overdosed, right? We changed the law so you can't be prosecuted for calling 911, and we provided immunity for the person they were calling about, right? We gave immunities for people on probation and parole for calling 911 and also being the victim. We also decriminalized the use of a medicine called naloxone in community settings, right? Naloxone is an opioid antagonist, meaning it blocks the effects of opioids. So say, for example, our agency passes out 35,000 of these in North Carolina over a couple years. It leads to over 4,500 overdose reversals in community settings by drug users, by people on methadone and buprenorphine, by family members, and just community people, just normal folks out and about, see somebody who's overdosed, we can do something about it. In North Carolina, you can use it with 0 civil or criminal liability, right? In North Carolina, we actually have one of the largest naloxone distro programs in the entire United States, mostly because we have very progressive legislation that was passed by our red state legislature. As Donnie also alluded to, we decriminalize syringes if you declare them to an officer prior to a search. We decriminalize syringes with residue if you declared it to an officer prior to a search. We also legalize syringe exchange, and we have 16 syringe exchanges in North Carolina. Syringe exchanges are proven decrease HIV, hepatitis C, decrease drug use, get more people into drug treatment in a community that doesn't have it. Only good things happen. You find people who've been kicked out of every social service for being a human, right? They use drugs, what happens? We kick them out, right? What happens to them? They keep using. What happens then? They can get HIV, viral hepatitis, overdose on drugs, get criminalized. Does that help at all? Putting anybody who has a mental health diagnosis that's untreated, that they may be self-medicating with drugs in a cage, right? Does that help someone, or does it make it worse? Is the first thing they're going to do when they get out after they've been stigmatized is stop using and turn their life around when they have a criminal record and nobody will hire them and nobody will allow them in housing and may not even allow them in treatment or detox because of their criminal record, right? Does that help people? No. So we have amazing leaders in North Carolina, such as Donnie Varnell, who's pushing the, let's not arrest them, let's divert them to, care. Let's divert them to social services, because we know putting them in a cage doesn't work, right? And humans don't belong in cages. They belong in supportive care. They belong in normal houses. They belong with their families. They don't belong in there, right? And we know that is the worst thing we can do for them. Yeah. So our agency's going to continue to push the fold in North Carolina. As you may know, we are a red state, but this is a bipartisan issue, and we forced it to be a bipartisan issue. We do legislative organizing, law enforcement organizing. We actually work with Don's police chief, who's amazing, named Bill Hollinshead out of Waynesville. And we do legislative organizing. We get people who use drugs, people who've retired from using drugs, people who have family members who use drugs, and we organize them and engage in legislative action. We're actually working on preventing employers from asking about people's criminal histories prior to the first interview and making that law in North Carolina. We have Republican sponsors for that. It's called Ban the Box or Fair Hiring. We're also working on raising the age so you can't be basically sent to adult correctional sites as a minor, which we do here in North Carolina, as well as New York State, if there's any New Yorkers here. so it's not just us. We're also working on enhancing our overdose prevention legislation, enhancing law enforcement-assisted diversion, because we know that's also a part of the solution, and also decreasing racism and structural racism in our treatment mechanisms, right? So if you look at drug users in a community, who uses more drugs, white people or non-white people? It's pretty much the same, right? Sometimes more white people. Who's in corrections? Who's in treatment? Who's in treatment? White people for the most part. Who's in corrections? African Americans, Hispanics, minorities, right? So we're working on peeling away that junk, that BS, because it ain't right, right? So, yeah. So just because you're in a red state doesn't mean you can't go after all of that, because as we see more overdoses in the Caucasian, suburban, and rural communities, you're going to get more buy-in and more legislative power to create change. And it sucks that that's what it had to take, but please, work with your legislators. In North Carolina, it's your last day to vote, register to vote, sorry, so please do that if you haven't. I have people here who can register you if you don't have any, if you haven't registered, please vote. Make sure, engage your legislators to work, because we're all talking about stuff, but if your legislator doesn't hear about it, and they probably aren't hearing about it enough, they're not going to change. So please contact your legislator. Please tell them you support evidence-based public health, you support methadone, you support buprenorphine, you support syringe exchange, you support overdose prevention. And don't think because you just live in a red state it can't be done, because here in North Carolina we've proven you can do it, and we have one of the largest overdose prevention programs. We have 2 really good overdose prevention nonprofits, and many more starting up. We have over 16 syringe exchanges since we passed the legislation. We had quite a few before the legislation, but it's not nice. I don't have to be arrested now. These things can all be passed. These things all can happen. These things can all happen with barely any money, which we've proved in North Carolina. And it's really, I really encourage all of you to take action, to step up. If you're curious on how to do that, feel free to contact me. And also, I'm talking about naloxone and overdose prevention kits. I brought a whole bunch of these with me. I'm over there. So if you want one, I can actually distribute it through our standing order, and I'm happy to give it to anybody here if you have a family member who uses drugs and you want naloxone. So I'll end it with that and appreciate your time.
Thanks, Robert. And a question for you, because I've known you pretty much since you got here in North Carolina, and I know how it was at the very beginning, because you didn't have that relationship with law enforcement. You didn't have that relationship in the communities. If you can just briefly, how was that a piece by piece by piece, or how did that evolve?
Yeah, so Donnie Varnell right here used to scare me. And I came from a little town called Brooklyn, New York, prior to living here, where I was running a syringe exchange and sex worker health organization. And when I came down here, I was like, oh, I should be able to sell things based off public health arguments. Why wouldn't anybody listen to that? I went to the General Assembly to try and work on advocating for legal change, and they said, what does law enforcement think? They called the Wake County Sheriff's Office, and they let them know what they think. So we started, we figured out very early on we had to engage law enforcement in order to get buy-in in a legislative level for legislative reform, but we also wanted law enforcement to be engaged in overdose prevention, in syringe decriminalization, in referring people who use drugs to social supports over incarceration. So we started through doing CIT trainings, crisis intervention team trainings, got to know some really great folks. We also asked every single one of our members, do you know anybody in law enforcement who we can talk to, who we can start talking about enhancing our messages, so then when we talk with law enforcement leaders to be more effective. We also started hiring law enforcement as our advocates. So if I walk in a room, I'm obviously a public healthy guy, I'm kind of nerdy, and I also have ear piercings. So they instantly normally know I'm not a narc, and they then look to the gentleman on my right or left who are members of law enforcement. They say the same message I do, and then they're like, oh, my mates think that. I'm hearing it from some of my peers. I'm more okay with it, and then you build. And right now we have over 1,800 members of law enforcement who are part of our network who are happy to assist us with initiatives. We also did a lot of media work to change the message on what's being said about harm reduction. So in North Carolina, we average over 300 articles a year on supportive harm reduction stuff because we're pushing the media to tell that story. And that has led us to having success and change. And we put it in key districts where legislators of power are and key sheriffs, so they are getting that message consistently from their community, which then when we meet with them, it's, oh, this is what I've been hearing, why wouldn't I support this kind of deal? So there's a lot of strategy we use to get their buy-in, but now, we're pretty blended with law enforcement, and we have some really great leaders across North Carolina who've helped us get in with a lot of them, and now we are able to present at the lobbies and at the sheriffs and police chiefs meetings, and it's just not even controversial what we're saying anymore.
Excellent, thank you. If you could pull up the infographic on the screen, and now we're going to have some time where you can at least ask questions and we can discuss with you. But when we started, I asked you, what do you need to know and what needs to be done? Where are you in the scheme of this infographic? Where are you in your practice and your personal life, and seeing where the gaps are and what can be done and what can be changed in that? But we have wandering microphones.
Well, I just wanted to, we have a question that someone has already posed, and this is for Dr. Teater and for Katie Getz. How was behavioral health involved in, or how is it involved with the treatment in primary care that you're working together to help those folks?
Yes, I'm a behavioral health clinician that works with Don, and I just want to say how much it changes things when a primary care provider is providing the Suboxone, that the primary care provider truly is looking at this person through a lens of whole person care, and that's really trickled out to the workforce and to me, and then to the folks we serve and even our community. There are so many people that in a primary care office, if they send them down the street to the mental health substance abuse provider, that might as well be 50 miles away. It's just so hard to get through that stigma, as Brooke talked about. And so when they know it's a primary care provider who isn't going to judge them, and we're able to say, he sees folks with addiction all the time, this is what he does, it's really opened the door for people to be willing to talk about the opiates that they're using. And we get to work together to help make that connection, whether that's just providing some of the education that all of these folks have talked about today, because we know there's a connection between mental health and substance abuse and physical health, but many of the folks we serve, they're just trying to get through the day, and they're not really able to make some of those connections. So just being in the same building and being able to offer those services through that lens has been really huge.
Can you hear me? Okay. We're going to be opening up for about 15 minutes of questions, and before we do that, I just wanted to remind everyone that after the plenary today, to go by the posters. We also have the job fair, but we are willing to stay, the panel is willing to stay here as long as you would like to ask questions, and they'll be available also after the plenary. So questions, and we have a mic over there that's traveling, and here, so questions for the panel? Comments? Oh, we got some.
When you're seeing addiction at the clinic level, how are you convincing patients about addiction? Because in my experience, when I bring this up to patients that I'm concerned about, I run into a brick wall. Even over time, when I've tried to break down those walls, it's been very, very difficult. And I think, unless I get buy-in, obviously, from the patient, any of these programs are just not going to work. So can you address that?
I think there's there's a little confusion, I think, sometimes how we look at the whole picture about people with chronic pain treatment and looking at addiction. People that are on chronic opioid therapy have brain changes just like those folks that take drugs illicitly. And I've experienced this also. Many times people come in and they say, you know, I have chronic pain, I need these medications, but you know, I just don't like the way they've controlled my life and I want to try to get off of them. And other people maybe come in that we suspect addiction is an issue, but they're not ready to hear that. I think there's a certain population of people that actually, and I've done this with a few patients myself, where you say, you know, these drugs have been changing your brain in a way that maybe is not healthy. And it'll lead in the future to more depression, more anxiety, other issues that I don't think you want to get into. I think there's a lot of people that actually would benefit from buprenorphine treatment, and you tell them, and I've told them this myself, I said, I don't know how much of this problem is pain, and I don't know how much is addiction, but buprenorphine treats both. So let's get you on this treatment. One of the advantages of buprenorphine is that, first of all, it has a ceiling effect, so it's very safe. It's very hard to overdose on it. But also, you don't develop tolerance to it. So you find a dose that works right for them, and they can take it and it helps their pain, and it prevents any of the behavioral issues that go along with addiction. So I have a number of people that probably have pain and addiction, and even if they don't want to necessarily believe in the addiction issue, just treating them with buprenorphine makes a big difference.
I was going to add something onto that too. So, like, if I use drugs or anything off-label, hypothetically, of course, I am petrified of saying any of that to my medical provider. And so, you know, there's things you can do in order to decrease stigma within your waiting room, within your service zone, to make people feel more comfortable doing that. So one is having active or retired people who use drugs occasionally come and talk. So people know, oh, there's people here just like me, that's not weird, and I can then maybe talk about it. You can start talking to your people who you suspect potentially of doing stuff, or if they take opiates or opioids, about respiratory depression. Not overdose, respiratory depression, because if I'm doing anything, specifically if I'm just on pills, I don't think I can necessarily overdose, but I am worried about respiratory depression. So we know Dr. Philip Coffin out of San Francisco Department of Mental Health and Hygiene, and the health department there, has found that if you use certain terms like respiratory depression, there's a lot more receptiveness, and then you can start engaging people more. Having individuals come and talk about overdose prevention as well, talking about naloxone, and doing like regular education with your patients, as well as offering perhaps like community events, barbecues. We're in North Carolina. Hopefully you support Eastern barbecues such as myself over Western, but I know there's some arguments here. Vinegar base. So, you know, just trying to break down the barriers and stigma, but I think like the most important thing is having people who've retired from drug use or in and off of drug use as communicators in waiting zones and doing education. So our program, for example, we go into methadone and buprenorphine clinics and provide harm reduction education to everybody who comes in, talk to them about risk reduction, talk to them about the great services at the site, talk to them about other supportive services to just break the barriers. And if we do it consistently, it's considered normal, and then people may be more interested in other supportive care. But I think also letting your patients know, like, I'm not penalizing you if you tell me these things. And I really want to know, and there's something, you know, patient confidentiality, and we want to talk about this, and if we don't talk about it, I can't give you full-hearted care.
Let me just also say that, you know, I've experienced a lot of folks like that, and they are very difficult. And you know, you can do your motivational interviewing, and you can do all these other things and try to get them to the next, you know, the next motivational level. But some people are just not ready. You know, they don't want to hear it, and we can't force them. You know, sometimes we just have to wait, and we have to do the harm reduction stuff, you know, and until they're ready.
Hi, I'm over here. I'm just curious if, as part of your practice or treatment, if any of you have pulled in alternative therapies such as acupuncture or massage, and any outcomes that you've had with that, if you have.
Being the only doctor, I'll speak first. First of all, let me say that the very last Mayo Clinic's Proceedings Journal had an article on alternative therapies for pain. And it's a pretty good article. But I will also say, I think it's important for us to understand we oftentimes kind of get pain and addiction mixed up. We think of pain as being a physical process and less of an emotional process, and we think of addiction as being an emotional behavioral thing and less of a physical thing. And in reality, what we know in particular with chronic pain is that the level and the suffering that comes from, the level of pain and the suffering that comes from chronic pain is mostly an emotional and behavioral issue. So I'm a very firm believer that behavioral therapies and behavioral treatment like CBT, mindfulness training, these other things to decrease the catastrophizing and help them claim victory over the pain is the most important thing we can do to treat chronic pain. So, you know, we talk about alternatives of treatment. I think behavioral therapy is the key. These other things help also because it gives them, I think, the opportunity, you know, yoga, acupuncture, massage therapy, all these things probably do help some people, but they don't help everybody. But it does give them a way to be more active in treating their pain, which I think is an important part.
Not being a practitioner, the only place I can speak for is we started Operation Opioid Safe as the Project Lazarus at Fort Bragg. They have 140,000 soldiers and families that they take care of. And we got engaged with them back in 2008. And at that time, they were losing in one brigade 15 soldiers out of 400 to overdose. And about 17 per thousand who survived an overdose. And we developed a risk stratification algorithm for pain management that brought in the behavioral health care. And since then, they've instituted, and again, it's a captive audience, and the Army can do this. They brought in acupuncture and massage and chiropractic care and all the other modalities that can be integrated into opiate treatment or non-opioid treatment. And the findings and the changes in the outcomes are remarkable with that. We dropped overdoses from that 15 out of 400 to 1 in that first year, and their opioid prescribing, and they used to be the #1 prescriber for opioids in the state, well, actually in the Southeast, especially during deployment times. They've dropped that by at least 25%, and the patient satisfaction is tremendous because they've integrated from the commander all the way through the family to the soldier. Anybody on opioids is being co-prescribed naloxone, so they know the risks and the benefits of that care. But showing that integration and bringing other modalities does make a difference. Now, when you go back to your place of residence and you're talking with your legislators and so forth, for the most part, we all know these things are not covered, they're not paid for, they're not easily accessible, and that's something that dramatically needs to change in order to further address the problem that we're all talking about today.
Thank you. I had a question about whether you're using information from the Adverse Childhood Experience study in your treatment of these patients. This was published almost 20 years ago and shows extraordinarily strong correlations between the degree of adversity suffered in childhood and the risk for addiction during adulthood. And the co-author of the study, Vince Felitti, emphasizes that unless you're treating the long-term emotional consequences of childhood adversity, you're really treating the smoke and not the fire. So I wonder if you could comment on whether that's included in the work any of you do.
We have recently tried to figure out how to incorporate ACEs into the work that we do. And so start on the mental health side and substance abuse in our assessment, we are using the ACE to determine folks' ACE scores and to really briefly provide that education. And then we've trained all of our staff in the community resiliency model, which can be a really brief intervention that we can use in a primary care office as well, that the providers can use just to educate people about if you all got a body, you've got a nervous system, and those get impacted by stress and pain and trauma, just to start that conversation and help make that connection and really normalize it.
Okay, well, I've been told we need to adjourn, but the panel will stay if you'd like to continue to ask questions or talk with them, but we would like to give you the opportunity to move on and do some things that are planned for you. I hope you enjoy the rest of the day. And thank you so much, especially Brooke.